Good evening, everyone, and welcome. I just wanted to take this profound moment and say thank you so much for allowing me to moderate. It's my pleasure to welcome you to this evening's CAEP National Grand Rounds. I'd like to begin with a land acknowledgement. As such, I wish to acknowledge that this land on which I am presenting from, living and working in, for thousands of years, this is and has been the traditional lands of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit, and is currently the meeting place to many and home to many Indigenous persons from across Turtle Island. We are profoundly grateful for the opportunity to work, live, and study on this land. My name is Taylor Bischoff, and I'm very grateful for this opportunity to host this evening's Grand Rounds. I'm an emergency physician working at Sunnybrook Health Sciences and Royal Victoria Hospital within Southern Ontario. I also have the pleasure on sitting in the Women in Emergency Medicine Committee through CAEP, and it is from that hat that I am moderating this evening's presentation. As I've mentioned many times, it's with great honor that I welcome our two speakers this evening, as well as our two other panelists. This evening's speakers are Dr. Juliana Deutscher and Tara Leach. Their work is invaluable to our communities, and they are experts within this field. Tonight, they will take us through the following objectives with their presentations. As stated, we'll begin and culminate the session with a panel discussion from very esteemed persons that will also be joining us later. CAEP Scientific Planning Committee has reviewed each presenter's conflict of interest submissions, and none of our speakers have potential conflicts this evening and have been identified, and no external support has been received for this webinar. I'd like to now introduce Dr. Juliana Deutscher. Juliana is a fourth-year emergency medical resident at the University of Toronto. She completed medical school at the University of Alberta, where she had the opportunity to develop a curriculum on screening for human trafficking in partnership with community organizations, including ACT Alberta. Prior to medical school, she was a board member of a nonprofit, Magdalena House Society, that previously operated a shelter for trafficked persons. Juliana will be starting in the Global Emergency Medicine Fellowship at Queen's University this fall, where she hopes to continue developing an improved approach to screening and care for trafficked individuals presenting to the emergency department. Tara Leach is our second presenter this evening. She is a primary healthcare nurse practitioner and a certified sexual assault nurse examiner. Tara addresses violence from four pillars: research, policy, education, and frontline clinical perspective. She is the founder and clinical director of Health, HEALTH Clinic, which stands for Healthcare Education Advocacy Linkage for Trauma-Informed Healing. The Health Clinic is the first primary care clinic in Ontario committed to providing patient-centered and trauma-informed primary health care to people aged 13 years and older who are at risk for, or who have experienced, or who are experiencing coercion, exploitation, labor, and/or sex trafficking. She has recently augmented the perspective of this clinic to focus on the needs for those who are working through mental health and substance use. Tara is the co-founder for the Human Trafficking Health Alliance of Canada. The Alliance is a nationally formed group of healthcare professionals who are working to increase education and advocacy for human trafficking in Canada and the intersection of healthcare. Since 2012, she has been a part of the Ontario Network for Sexual Assault and Domestic Violence Treatment Centres. She's a forensic educator with the Ontario Sexual Assault Nurse Examiners Program. Additionally, Tara is a part-time professor at Algonquin College in the Ontario Victimology College Graduate Certificate Program. Without further ado, I will turn the platform over to our presenters. Thank you.
So thank you again to Taylor and to the WEM group for the invitation to present to you all this evening. And thank you for taking the time to come listen to this presentation. It is a privilege to start this conversation on a pandemic that has been prevailing in Canada long before COVID. I don't have any financial disclosures. However, I would like to quickly note that although many of the materials that I've used in creating this presentation and many of the organizations that I've worked with do have direct work with individuals with lived experience, these slides directly have not been reviewed by somebody who has lived experience.
For myself, in terms of disclosures, I have received financial support for presentation delivery and moderation from Bayer as well as Merck for presentations unrelated to this one.
There are many outstanding organizations who have helped contribute to this presentation and ongoing development of medical education in this area. I unfortunately couldn't list all of the names that have contributed to this work, but I have included the names of my current supervisors. We recognize that this content can be triggering, particularly for those who may have been exposed to violence, exploitation, or abuse previously, and we've been very careful not to include any imaging that could be harmful. I recognize that this evening there might be a great spectrum of different training backgrounds pertaining to human trafficking care. And so we've tried to create a series of objectives that are going to try and look at this entire spectrum. So starting with actually bringing us onto the same page of the definition of human trafficking, what it looks like when it comes to the emergency department, and then transitioning to Tara, who's going to give us some education on how do we have an approach to providing trauma and violence-informed care and identifying our next steps, followed by a panel discussion that will be able to explore a lot of this further. So I'd like to start by giving you all a case. So we have a patient who's presented to your low acuity zone, a young female who's actually here for her third visit for a dry cough. She does not have COVID. There are no overall concerning features on history regarding the cough, and her vitals are normal. You actually look at her vitals from the previous 2 visits. They were also normal. She had a chest x-ray done at the visit just 2 days ago, normal. Blood work, normal. Cardiopulmonary exam, normal. You suspect that they probably just have a viral respiratory tract infection and plan to send the patient home, but there's just something that you can't quite figure out. She seems very fatigued. She's avoiding eye contact, fidgety, and asking repeatedly when she might be able to leave. So you come back to your medical history and you're trying to establish a bit of a better sense on why she's so keen to leave when she's clearly also concerned, given that this is her third visit for the cough. And she explains that if she doesn't get back to work, she's worried that she's going to lose her job. You follow up with some further social history questions, particularly finding out that she's actually living with her partner and that's her only source of income, access to food. And it was actually her partner who recommended that she recently enter the sex trade, as this might be the only way that they would be able to get enough financial means to survive. She's been concerned about this cough because she's worried that it might be something infectious that she could have been exposed to at work. So on further screening, she was identified as someone who is a victim of human trafficking. Now, I recognize that some of you might be hearing this and thinking to yourselves, in the Emerge, how do we take the time to build that kind of rapport and have that sort of conversation with a patient? And then some of you might also be thinking, okay, great, so we've identified this person, but what do we do now? And so I hope that this evening we'll be able to answer those questions for you. The reason I shared this case is I just wanted to demonstrate how easy it is for human trafficking to present. So this was just a young female who came in with a cough on a return to ED visit. And it was that easy that was human trafficking. It's a bit of a stretch of an analogy, but in a way, human trafficking is like an aortic dissection. So it's something that can present with any combination of symptoms, and it's a diagnosis that we've probably all missed. But I hope that we can again provide you the tools this evening that we can increase our sensitivity to identification of human trafficking in the ED moving forward. So what exactly is human trafficking? So this is something defined by the United Nations as 3 components, which are act, means, and purpose. And what that means, so act is defined as, for example, recruiting someone to work in the sex trade through means such as coercion, fraud, threats, deception. And I will add in here that a lot of times the person might not actually realize that they're being exploited. And it's ultimately for the purpose of exploitation, be that labor exploitation or sexual exploitation. And so I'm just going to add another example of a layer onto this. In Canada, a common way that this occurs is through something called grooming. So this is a situation in which the trafficker has identified a vulnerable individual and they actually form a relationship with them, often romantic, but it can just be in the form of a support person. Throughout this grooming process, the trafficked person actually develops an increasing dependency on the trafficker. And the trafficker then uses this to their benefit to then exploit this individual. So they might become dependent on them in terms of their social support, shelter, food, access to income. And the trafficker then uses that to encourage them to enter different forms of work, be it sex trade work or unsafe labor or stealing as a means of providing them income for their own personal benefit. So when we look at then kind of different myths of what might also be associated as human trafficking, I find it important to distinguish between smuggling and human trafficking. So human trafficking might actually be better labeled as human exploitation. Smuggling is something that involves crossing an international border, and it's an illegal entry into another country. So although human trafficking can involve this, it doesn't have to involve smuggling. And in fact, in Canada, 2/3 of our cases do not involve an international component. So 2/3 of human trafficking cases in Canada are actually domestic. Another piece that I like to distinguish is that it's important to note that all sex trade work is not human trafficking. And furthermore, that all human trafficking is not sexual exploitation. So I had mentioned when going through the act, means, and purpose definition, something about labor exploitation. So I'd just like to take you through a bit of a case example of what that might look like. So you have a young male who's brought into your trauma bay from the workplace. They unfortunately had a severe traumatic injury to their arm, which got caught in some equipment. The trauma team is activated and a full assessment is completed. And while the patient is awaiting to go for surgery, you're discussing with them some workplace injury documentation, which alerts you to some flags that suggest that this person actually might be trafficked. So what exactly is labor trafficking? This is something that can include working in unsafe conditions, working for inappropriate pay or no payment, or payment through food or accommodation. And it may include not being able to take breaks or leave their workplace. I gave you that statistic about 2/3 of cases of human trafficking in Canada being domestic. In regards to labor trafficking, these again can be domestic cases, but they're definitely a higher prevalence and risk for individuals who are newcomers to Canada or on a temporary foreign worker license. Although there are increased factors in some of these groups that I've mentioned, such as temporary foreign workers, vulnerable youth, low socioeconomic status, ultimately in Canada, human trafficking does not discriminate to age, ethnicity, gender. Anyone can be a victim of human trafficking. In terms of Stats Canada, the majority of individuals being trafficked do identify as female, and up to 1 in 4 are actually minors. Now, when we look at the red flags, you actually already have a lot of these in your toolkit. You might recognize some of them from training that you've received in intimate partner violence or child abuse and neglect. And so I encourage you to use those additional lists that you have in your mind, and then to add in something that's a little bit more specific to human trafficking as well. So keeping in mind that although human trafficking often kind of gets lumped under the umbrella of intimate partner violence, it is its own separate entity, particularly with when you start incorporating some of those labor trafficking cases. So some things a little bit more specific on your red flag list for human trafficking would include the companion answering questions on behalf of the patient not being in control of their personal identification documents. So this would be something that might be more flagged by the triage nurse. Tattooing or branding. So unfortunately, a lot of traffickers have different tattoo brands that they will have on some of their trafficked individuals. And this is something that the police actually follow, recognizing that there is branding occurring. There's minors spending time with an older partner. So this might cause you to think about that grooming example. Loss of sense of time. So this is partly due to just the extremely physical demanding work hours, or in cases where an individual might not actually have the freedom to live the home of where they're staying with their trafficker. This can also present as lack of knowledge of their surroundings or location. However, with those last two, I just like to emphasize that you don't have to be held captive to be considered trafficked. So that's kind of one of those misconceptions that can sometimes come up. And it comes back to this grooming example where a lot of times traffickers do have some sort of relationship, be it that they're a family member, partner, friend, or whichever, with the individual that they're trafficking. And this sometimes get referred to as the invisible chains that kind of keep pulling back that person to the trafficker. So what is the role in the emergency department? So I've just included this screenshot from the University of Toronto Competency by Design, EPAs. So recently when we switched to CBD, it was recognized that human trafficking is a core competency that emergency physicians should be able to recognize and manage. And the reason for this is that research in the States shows evidence of individuals that are being trafficked presenting to the emergency department while being trafficked and are often not being identified, and the opportunity to provide access to resources is being missed. As emergency physicians, we're in such a key position to recognize individuals who are being trafficked or at risk of trafficking, given that healthcare might be the only setting that they actually come into contact with that has the opportunity to provide them these resources. Most importantly, because we are so fortunate to be connected to such a vast multidisciplinary team. One study found that over 80% or 87.8% of human trafficking survivors actually reported having contact with the healthcare provider while they were being trafficked. So this was a study done out of emergency departments in the States. So I'm just going to go through a few different barriers of why, now recognizing that this does come into contact with the emergency department, why is it something that we're still not screening for or able to provide care for? So you might be wondering why I have a picture of a red unilateral swollen leg. And one of the analogies that I kind of like to paint a picture of in regards to human trafficking is that it's kind of this diagnosis that we think, okay, it comes to the emerge. There's lots of things that come to the emerge that we don't necessarily think of as an emergency. So why should we be allocating so much time and so many resources to somebody who might be trafficked? And I think of it in the same way that I think about a DVT. So a DVT in itself is not something that is necessarily emergency in that first day. It's not something that's going to be potentially fatal in that first day. So in its isolated form, it's not really an emergency, but we screen for it because if we miss when it develops to a PE, then that's something that could obviously be fatal. And so an initial presentation of human trafficking may not be fatal, but if that initial opportunity to offer help is missed, then we can result in serious health consequences, including death. A second area of concern that sometimes gets brought up, and this is something that I myself have had a hard time with when I've been trying to incorporate more screening, is this feeling that we need to be the judge and we need to be playing the hat of being a lawyer and determining 100% if this person is being trafficked. And I think it's important to remind ourselves that that's not our role. And in fact, when you kind of have that mindset, you can end up asking extra questions that can end up being more harmful to the patient. Our role is simply to identify people that are at risk and then to be able to connect them to much needed resources, which brings us to our third challenge, which is, okay, but what resources are there? And we'll definitely be getting into this a lot more with Tara's presentation as well as our panel discussion. But fortunately, with increased awareness on human trafficking over the past decade, there have become a lot more resources available, which again, we'll touch on. So we can connect them to key supports and resources, including social work, community organizations, and I'll just highlight the Canadian Human Trafficking Hotline, which goes through a whole bunch of very specific resources specific to your local community. And perhaps the biggest barrier of all is time. Time for the patient who is worried about spending time away from the trafficker, time to provide the in-depth rapport-building, trauma-informed care that is much needed, and time that is being taken away from all of the other patients that we're thinking about in the department. So this is something that I hope that we'll have good discussion around in the panel as we brainstorm how we can be better building interdisciplinary teams, both connected with our community and in the department, to have an ED human trafficking pathway that provides the best care to our patients. And with that, I'd like to pass the torch over to Tara, who will be addressing those additional learning objectives. Thank you.
Thank you for the very excellent presentation so far. And thank you so much. Welcome, everybody. So I have the privilege to be able to talk to you about trauma and violence informed care. I use the terms trauma and violence informed care because that's actually what is being proposed. And certainly in terms of policy and procedure development, there are some wonderful tools, and that is part of our Canadian public health. So when we think about trauma and violence informed care, at the crux of it, the single most important step to providing sort of holistic and trauma and violence informed care is that trusting relationship. And that really begins at the first point of contact. And when we think about somebody who is being trafficked or a person who's experiencing any level of violence, this becomes something that's important to establish quickly. And that first contact can be something to really pay attention to. Oops, pardon me as I go here. The ideal approach to integrating trauma-informed care principles is to look at the big picture at all levels of the environment that affect our patient's experience. This involves integrating trauma-informed or trauma and violence-informed care at the institution level, consideration of physical spaces in the environment for clinicians and non-clinicians, and therefore ultimately affecting the patient's clinical and non-clinical experience. So when we think about trauma and violence informed care, it's about more than just your interaction with the client. It's about the overall environment with which you work in, how you're supported as an individual clinician, because of course that's going to affect on how you receive and care for your patients. Sometimes within your organization, you may have criteria or a mandate that references client-centered care. And a trauma and violence approach to care could be new for you. It could be something that you've heard about before. And I'm hopeful that with today's presentation, we'll go through how do you practically apply the trauma and violence informed care. You'll see in terms of the listing of there that what is one side client-centered and the other trauma, violence, and informed care, you can see similarities and parallels between the two. Clients who are being trafficked may not be our easiest clients. You may be inheriting a history of negative experiences with people in positions of authority and power, which may or may not be directly related to yourself as a medical provider. Oftentimes we come into a room, and since we identify ourselves as being helpful and non-judgmental, we fear our clients will see this within us. And with some clients, you may have to work to earn trust by creating a safe space and being thoughtful about your approach, your tone of voice, your demeanor. All of this will matter in building safety. Being a trauma-informed provider means being thoughtful about all aspects of trauma experienced across the lifespan. The next slide, perfect. So establishing safety in the ER. A trauma-informed approach recommends creating a sense of calm, security, and safety to reduce the patient's distress and minimize the risk of re-traumatization. I will say for 15 years of my 22-year-long career, I spent those in the emergency room. And when I think about creating a sense of calm and security, that can be a challenge in terms of the environment of the emergency room, but it is actually possible. I want to remind you that these first interactions, people are likely to be scared, feeling vulnerable, and they could possibly be in pain. They may often be deprived of sleep and food and may be experiencing the effects of drugs or alcohol. This might cause patients or clients to come across as difficult or uncooperative. Certainly appealing to somebody by taking care of their basic needs can go a long way of building and establishing that trusting relationship. I will offer to you to please use caution when you're interpreting patients' body language, their overall mental status when you're doing that evaluation, because reactions may be influenced by the survival responses in fight, flight, or freeze. These reactions occur in response to a perceived harmful event, attack, or threat to survival. Triggers of trauma or trauma reminders can be anywhere and might include room temperature, bathroom accessibility, loud noises, bright lights, among other things. These trauma reminders might also cause physical reactions in your patients. I encourage you to react properly if you notice these changes within your patient's physical response, and ask what they are feeling and if there's anything that might make them more comfortable. There's some examples on the slide in terms of creating calm. So whenever possible, minimize that sense of hurry. Start to be comfortable with silence, being comfortable with casual conversation, speaking at a moderate pace and tone. Certainly the art of practicing active listening. A lot of times we can feel so pressured to be able to come up with an action, sort of quick treat and street. But in the case when clients have experienced trauma, the cases of trafficking or clients who have experienced trafficking, please listen, because a lot of times the details that can be shared can provide you some clues and identify some red flags that might be shared. Please make sure that you're making eye contact as culturally appropriate. Position yourself at eye level with the patient and recognize the potential power imbalance by conveying an attitude of collaboration. Establishing trust and safety begins with honoring privacy. Interview your patient alone, regardless of their age. You want to establish that relationship in terms of who might be with them and that might have accompanied them to the emergency room. You want to be able to ask them questions privately about that. You also want to be able to outline the boundaries of confidentiality and maybe present what you might be discussing so that they are informed and are able to make a decision about what they may want shared with the person who is with them and what they may not. If this is always your practice, so meaning if it's always your practice to interview your client alone first to establish these boundaries, then everyone else around them will see that it's universal, that it's not just a one-off that you're doing this. And so this will then lessen any unnecessary attention drawn to your client. In terms of COVID and restricting visitors, same thing happened with SARS. These were wonderful times to be able to ensure privacy for our clients because it just limited the distraction of visitors. Perfect. Thank you. Whenever we communicate with clients, we want to make sure that we are communicating with a non-judgmental and a culturally appropriate. All people deserve respect for their integrity and privacy. Be informative, not inquisitive. It's not necessary to know everything about the patient's culture or experiences to create a safe space. The patient should feel physically and emotionally comfortable enough to drive their own process of self-determination, sharing at moments in which they are comfortable and feeling able. On a population level, victims of trafficking have lost their agency to make their own decisions. Each decision a patient makes is a small step toward regaining that agency and creating a sense of safety for themselves. In terms of language, interviewing and screening for violence should happen privately and in the patient's preferred language. If the patient's preferred language is not English, use a qualified staff member, a trusted language line, or a trauma-informed interpreter to assist with your assessment. Due to the dynamics of trafficking, do not let an accompanying person interpret. It may be good for you to know that our center, our hotline for Canada, does offer services in a large variety of languages and really can be an access and a resource for you to consider. For those of you who like mnemonics, this can be a helpful one. So this was initially developed in the US and has been adapted for human trafficking, but it just becomes a reminder. So privacy we've reviewed. Sometimes there can be some discussion on screening for trafficking, screening for violence versus universal education around relationships and healthy relationships. There's some tips in that in terms of how to ask questions, how to phrase things in a non-judgmental way, and then some guidance in terms of how to respect and respond to a disclosure. So this is something that if you Google the PAIR tool, you may come across some helpful resources that may help you both with intimate partner violence as well as with human trafficking. Okay, the next slide. Many of you have likely attended workshops or education sessions that have quoted the statistics of violence. I think that we know in our hearts and souls that violence is affecting more than our relationship, more than our population than we'd like to admit. We know that experiences of violence are pervasive. And we know that normalizing this experience and linking the understanding of why we ask these questions is important. We ask about violence because we know that these experiences can affect our mental health as well as our physical health. These could be relevant in the context of violence for those accessing services in the ER for substance use disorders, syncope, mental health, including psychosis and suicide, and then reproductive concerns and pain. Some examples are on the slide in terms of how to phrase things, in terms of that normalizing and applying that trauma-informed approach. The next slide. Whenever possible, you should ensure that the ability to be able to identify or track a person is limited within the ER. What I mean by that is that some emergency rooms, by the virtue of their electronic chart or record, whiteboards, or other communication tools that can be within your department, there are ways in which you can de-identify people. And so these may be policies that you already have within your department. And I encourage you to access those and to utilize those. Whenever you're documenting in terms of a history shared, be as objective as possible. With permission, complete a head-to-toe examination. This can be an experience of those of intimate partner violence, sexual violence, human trafficking. It's important to be able to complete a comprehensive head-to-toe. And the reason being is that oftentimes that can identify old or acute injuries. I would encourage you to screen for strangulations with any instances of interpersonal violence. Screening for strangulation is something that has a bit more of emerging evidence to be able to show us and to demonstrate just how lethal this can be for clients. I think it's well documented with the population of intimate partner violence that we increase lethality, so the risk of somebody being killed, by 7%. Or by 7 times. We don't have this research in terms of human trafficking, but certainly we can adapt it. Certainly the understanding of what strangulation is from a physiological point of view can help us understand why it's important to screen for it, because of course it can be related to those very vague symptoms of why and which a person may be accessing an emergency room. Please pay attention to opportunities that you can reduce harms and provide interventions that can reduce risk. Moments like HIV PEP, so post-exposure prophylaxis, or PrEP, pre-exposure. vaccinations for hepatitis B or Gardasil to help protect against HPV, emergency contraception, etc. Watch your language and your assumptions in your documentation. Charting should be objective with verbatim quotes whenever possible. Please refrain from language like alleged or claim, and please use states. And whenever possible, as mentioned, quote your patient in terms of what it is that they are disclosing to you. Use appropriate diagnoses, and use diagnoses that could be that things are unspecified by being able to link your history shared by your client and adapting that to be able to link to your treatment plan. So like anything that comes into the emergency department, you are discussing subjectively in terms of what a client has shared with you, in terms of your assessment, in terms of what that might reveal, your diagnosis or some of the things of your differentials or things that you might be suspicious for, and then of course, a plan of care that defines your treatment plan and your discharge. So when we look at the goals of the emergency department with a potentially trafficked patient, I mean, certainly today, we've gone over in general in terms of trauma-informed care and adapting those principles. But when we look at the emergency department with a potentially trafficked person, we want you to address the acute presenting illness or injury. That's why people are accessing the emergency department. That doesn't change your plan of care or your approach of what you're doing already. When considering the presenting illness or injury, to the best of your ability, please consider if this is intentional or accidental. So much like what's been mentioned, the training that you have done to be able to identify child abuse, to be able to identify intimate partner. Just what you're being told, is the narrative that's being described, does it match what it is that you are seeing? Trying to establish safety in the emergency department. So that's safety between your approach with your client one-on-one. That is also the safety within your environment. Try to control as much as you can in terms of the chaos that can be around. When you're interviewing something, considering your space and what's around you, consider that privacy. Make sure you're adhering to privacy policy and interviewing that client alone. Offer additional resources if appropriate and available. So consider, are you attached to a SANE? SANE is the Sexual Assault Nurse Examiner program. Do you have connection to another forensic program? Sometimes in other provinces and territories, these can be called SAFE, Sexual Assault Forensic Examiner type programs. Is there ability or accessible to social work? Could there be somebody else that you might be able to work with? What does access to victim services look like in your area? Just remember, it's been mentioned that the goal is not to elicit a disclosure. Your role as a provider is not to investigate or confirm the presence of trafficking, but to respect the autonomy of the patient in front of you, meet their healthcare needs, and empower them to seek additional support on their terms. This is not about rescue. This is about empowerment and self-determination. So people may ask themselves, what can I do to be ready in the emergency department? So again, much like your attendance today, you are interested in wanting to know what human trafficking is and what could be the consequences. So I encourage you to attend additional workshops and read additional articles that help you understand both the physical and the mental health consequences of what it is to be trafficked. Recognize and do some work on on self-reflection on where your personal biases may be, whether they are implicit, conscious or unconscious. Like it's really one of those things that is work between you as an individual of where it is that you may be able to discover a bias within yourself. Become familiar with how to identify, assess, and document and refer cases of human trafficking. Know your options for survivor advocacy and self-determination. Another resource to see what's in your community is their access in terms of peer support and thinking about linking in terms of age, what is relevant for youth versus an adult population. And to understand the stages of change and practice the skill of motivational interviewing. The next slide, please. Sometimes I'll be asked, what do survivors want from us? What do people who have been trafficked, what are they looking for within us as a healthcare provider? What they're looking for overwhelmingly is that they want you to be non-judgmental. They want you to listen. They want you to offer information and support. They don't want you to push for a disclosure, and they want you to provide ethical care. And so for all of us who are licensed, we have ethics attached to that license. So whether you come from the nursing discipline like I do, whether it's the College of Physicians and Surgeons, you have ethics as part of your licensure. That is something to always reference. And you'll see very similar language to what you see for that trauma and violence informed approach within that code of ethics. And our clients can hold us accountable to that. Okay, thank you for moving ahead. So remember that the psychological coercion involved in trafficking makes it difficult for a victim to disclose or exit their situation. Not for everybody does it solve things by people leaving. This is the same case for intimate partner violence as it can be for sex trafficking. It can start the process in terms of using motivational interviewing techniques and really adapting that in terms of a person's stage of change. And it really speaks to people when you understand the context of their situation, when you see their behavior or see through their behavior and understand sort of what it is that it's going on. Sometimes when people are acting aggressive or might be interpreted that they're acting aggressive, a lot of times that is really defensive. There's a nice quote in terms of that has been offered certainly by Heal Trafficking and oftentimes offered by a doctor named Hani Stoklosa. So do not take patients' decisions to stay in abusive situations or relationships as an indication that your efforts have failed. Your supportive words and kind actions carry weight and may make a difference in the future. I will certainly share some of my examples of working in the emergency room and clients who have come back. And they have come back because on that visit, when they were there for another reason, they were made to feel safe. They were made to feel heard. And so they, yes, indeed, came back to be able to access care once again. The next slide, please. This is a wonderful website to be able to access. This actually describes the victim mindset and the stages of change specifically for human trafficking, in particular, sex trafficking. So this has been a person who has worked with the stages of change, who has really adapted and taken a look at that stage of change and worked at that specifically for human trafficking. It is very useful to be able to read through that, to be able to think of where that person, what they are experiencing and where they're at in terms of their stage of change, to be able to think about exit or other options and that beyond. The next slide, please. This may not be showing. So this was a video that I had thought that I'd put in here, but that is okay that it is not there. It is about 2 minutes long. We can sort of advance forward, forget about it for now. And then what we can do is come back to it. Woo. Okay. So in terms of our next, oh, sorry.
I'll pull up the video from a different format of screen sharing. I'll let you continue talking, but I'll try and pull it up for you.
Okay, thank you. So thinking about next steps. So we've talked about a trauma and violence informed approach. We've looked at some practical applications of that. Now we're thinking about next steps. Should we be a person who has identified somebody who is being exploited or who's being trafficked? So the next slide will sort of take us through what we consider for a safety plan, right? Whenever we are thinking about a safety plan, we want to make sure that that is patient-centered. We want to make sure that we can confirm contact information for our client. What is a safe way in which we're able to access them? Not everybody has access to technology. So in what format are we able to access a person to be able to discuss safety today and safety in future? In terms of attending to their medical needs, when is it appropriate for them to be able to return to the emergency department if necessary? Do they need that level of care? Where else might be able to access care? In terms of resources, taking a look at alternatives in housing that might take a look at shelter, might take a look at things like counseling that might be available through our Ministry of Attorney General where people have been a victim of crime, or they might be considered elsewhere within our areas, where we might look to the resource and that for the Canadian Human Trafficking Hotline. This is a very helpful hotline that is available 24/7. It is a responsible person on the other end of the line that is being able to talk to you as a provider, as well as your client or the person of concern. You may, within your network, in terms of your emergency department, be able to refer to social worker, to be able to have other clinic referrals, to be able to look at relevant community resources. So is there somebody that you may be able to access to follow up for a head injury outside of the emergency department? If an unintended pregnancy has resulted, are there areas in which you can refer clients where people can have access to medical abortion or a surgical abortion, depending on where it is that they may be in their gestation? Is there a forensic nursing program that might be accessible to be able to help people if they want evidence collected, if they want to involve our criminal justice system? Victim services is across our nation. So where is that in terms of relevant for you to be able to access a victim service advocate? Oftentimes there can be funding and things to be applied for. Things can be accessible in terms of TAP2 removal, taking a look at substance use type of treatment programs that wouldn't be funded otherwise. So there's a wealth of things that actually could be funded under the idea of the funding envelope and that around human trafficking. The next slide, please. This is just some information about our hotline. This is again across Canada, 24/7 accessible for you. They have wonderful resources that could be placed actually within your emergency department to be able to have something on the wall or some literature in that can be available. They have got a couple reports in that on their website looking at trends in Canada, looking at avenues and looking at our missing and murdered Indigenous women. So there's actually a wealth of resources that can be there in terms of our Canadian Centre to End Human Trafficking. The next slide. This was mentioned sort of at the beginning and introducing. This was an idea adapted from what they have done in the US. So in terms of through HEAL, we have adapted that with permission to be able to have a Canadian chapter. And so who we are is a bunch of healthcare professionals that are working across our nation. Our goal is to make sure that we have representatives from every province and territory within Canada to be able to discuss human trafficking, our Canadian healthcare system, and where are there opportunities for advocacy? Where are there opportunities to be able to share our frontline experiences, to be able to support one another? Too often we will work in silos and that's then not working together. So in the spirit of sharing and in the spirit of trying to be able to advance and advocate for this important topic, we have been working together. So things and projects that we've been working on is taking a look at ICD coding to make sure that we have coding available for traffic and exploitation. Things that we've been working on together is around a curriculum assessment, taking a look at what's out there as it pertains to human trafficking. Does that meet the need in terms of our healthcare population? And having a rubric to be able to evaluate that. Other scenarios that we are working on, we are working with our International Center for Missing and Exploited Children to be able to look at trauma-informed scenarios and giving you practical application to that. So there's quite a bit of work and some excitement within our network. It is all volunteer-based, but certainly with the passion of people who are seeing this within their work, we're trying to work together and lessen the burden on all of us individually and are trying to be stronger together. Next slide, please. This has always been an important quote that has followed me really throughout a lot of my career. And as healthcare professionals, we will treat the symptoms, right? And oftentimes when we think about trauma and trauma symptoms, I will think of a trauma tree in terms of that fruit that we might see within the emergency department, symptoms of psychosis, depression, anxiety, et cetera. But it's how we discharge that speaks to what we believe about the disease. And so it really is something that when we are thinking about our clients, we are being thoughtful about holistic trauma and violence informed sort of client-centered care. We are really taking in all of those symptoms, trying to really get to the root of what the problem may be and be able to sort of help that person feel empowered and determined and self-determine their next step. So I've always find that this quote has really resonated with me and I offer it to you. And that should conclude my part of the presentation.
Thank you both very much for presenting. We're now going to transition to the question and answer portion of the evening. And at this time, I'd like to introduce two other very important speakers that we are very grateful to have with us this evening. I'm going to begin by introducing Fiona Douglas. She's an anti-human trafficking advocate at Covenant House, Toronto. She's an extensive experience supporting and working with survivors of human trafficking and many vulnerable populations. She's also worked within the healthcare system, more specifically, child and adolescent mental health, the mental health unit within William Osler. She loves being a social worker, and that is her profession, and she appreciates any way that she can give back and contribute to bettering the lives of others. And I'd also like to introduce Julie Neubauer. She is Covenant House Toronto's manager of anti-human trafficking services. She's currently been in this role for the past 7 years. Julie supports and coordinates the agency's diverse and multi-service anti-trafficking program for young women ages 16 to 24. Julie provides direction and supervision to the agency's 3HT-SE advocates as they share an active caseload of 52. Since July of 2015, they have provided case management and direct support to over 220 survivors of human trafficking. She has developed and now oversees the agency's 3-tiered housing response for this unique population. Beginning in 2015, she established the 2 crisis beds for survivors, where since this date, they have supported over 120 young women. In 2016, she opened the Rogers Home, a 2-year transitional housing program for survivors of sexual exploitation, where they have supported 20 young women in their recovery. In November 2018, they saw the opening of the Avdale Home, which provides more rapid care and support for survivors of sex trafficking and exploitation. To date, they've provided immediate crisis care to over 29 young women seeking respite, recovery, and exiting supports. She also manages the Public Health Agency of Toronto's funded peer mentoring program, the Peace Project. The program provides young women with lived experience with unique opportunity to mentor girls in the hopes that together they can create and define the tools and necessary skills to address and manage the trauma and trauma symptoms associated with sexual abuse and exploitation. Julie also supports a YIT, or Youth in Transition advocate, to her HTSE team. The individual provides short-term management to young people who are at risk of, involved in, or exiting sexually exploitive circumstances and who have direct involvement in the child welfare system. Community consultation, training, and advocacy are all an integral part of Julie's role as a manager to this program. She frequently collaborates and provides consultation to other community organizations across the province and nation this evening to establish their own anti-trafficking programs. She has been interviewed by multiple different media outlets on the issues of human trafficking and is often sought as a speaker to facilitate on this topic. Julie worked as a sexual health educator, counselor at the House Community Health Centre before joining Covenant House 18 years ago. She's an accredited Ontario teacher and holds a bachelor's in education from the University of Toronto and a master's in education and gender studies from the University of London, England. We're profoundly grateful for everyone's time this evening, and I'm now going to open it up to some of the questions that were submitted beforehand through social media. I also invite any panel person to speak on any of the topics. All of the questions are kind of open-ended. I'm going to begin with my first one of the evening, which was, is human trafficking a mandatory report? So breaking this up within persons over the age of 16, over the age of 18, and if so, who does one contact?
I'll maybe let Tara go into this one further, because I was looking at the specific colleges across the different provinces today to see if there is variation between provinces and things, but Tara probably has the best kind of explanation from the actual legal terminology.
Yeah, so no, I'm totally happy to go into that. So in terms of looking at for whom you would report to, so under no circumstances as a healthcare provider are you contacting the police outside of scenarios of gunshot wounds or somebody feeling homicidal, or even sometimes, depending on your scenario, it might be for people who are feeling suicidal. Depends on where you work. In the case of human trafficking or exploitation specifically, who you might be reporting to is, of course, your child and family services. So a lot of times we can use the terminology Children's Aid Society, but that terminology has gone a bit out of vogue in terms of our Indigenous population. And now that we'll discuss that in terms of child, youth, and family services. In that obligation to report, it can absolutely vary by your province and territory, and it can really vary in terms of how it is that that is executed. So I've had the privilege of being able to travel around to many of our provinces and territories within Canada to be able to ask this question. And universally, it seems, under the age of 16, there is a duty to report to your child, youth, and family services, and that will be determined by your legislation, by your province and your territory. And that'll also be determined in terms of where you're licensed. And then over the age of 16, many provinces and territories have adapted, just for purposes of youth homelessness, as well as for specifics for trafficking and exploitation, they've adapted a voluntary in for youth in terms of our child protection. So here in Ontario, over the age of 16, but under the age of 18, you would be able to work with that youth and negotiate a call to our child and youth family services. And what that might provide access to is some financial resources that may change that sort of socioeconomic scenario that might be driving a person to maybe considering sex work. I think it's always important for healthcare providers to know this is in addition to, not directly related to that question, but when we look at sex work in Canada, people under the age of 18 cannot consent in terms of looking at sex work in Canada. It's really important to be able to differentiate the age of 18 and that under our Canadian Criminal Code, and the age of 16 that dictates the age of consent for sexual activity. There's, of course, close in age rules to be able to pay attention to as well, but just consider those things. And the reason why that's relevant and kind of attached to your reporting is that sometimes your interpretation of what risk may look like or what choice may look like, may drive in terms of what your knowledge of our criminal code is as well. So again, to recap, under the age of 18 or the age of 16, reporting to child, youth, and family services when you are concerned about neglect or you're concerned about an abuse of position of power or a person experiencing violence. And then from 16 to 18, it can be a negotiation. Sometimes there can be opportunities available. There are some provinces that go 18 and younger, but they are few and far between.
Thank you, Tara. So important to distinguish between basically the age of consent at 16 and whether or not you are able to consent to sexual activity. Moving into one of our questions from the audience this evening, it was posed, how do you deal with the companion who is answering questions for the patient? Tara, your presentation touched on this, one of the COVID silver linings of having no visitor policy, but anyone else, any tips or tricks that they've used in the past to separate persons, or perhaps get the person who's there, the patient, to answer, or your client rather?
I think it's really helpful to have posterings, to have notices. Again, I agree with you, Juliana, that COVID helps out a lot, that you can only have one person in. But if you can have protocols and an understanding amongst your teams and the organization posted around so that people know that it's one person in, that confidentiality in the privacy of the individual being seen, that the physician or the nurse or the social worker in that circumstances has something to fall back on, to be able to rely on and say that this is our policy, this is what we need to do. It's really important that we get the information from this individual. Can I ask you to step out? We need to do some procedures. We need to ask some questions, and to be relying on the protocol of the organization instead of trying to get into some sort of a power struggle around that. And again, it's important to find the moment to pick your battle. That if it seems to be going sideways on you, you don't want to engage in this because the young person in front of you who may in fact be trafficked or may be working, you want to establish a relationship with them. It's not to set up this power struggle with the other individual. And you pick your battles as it was, and find another opportunity or a moment to build an alliance and a rapport with the individual who you do have the concern about. And set up some other moments during that session or at other times to continue to build a rapport and get the information that you need.
Yeah, I think picking that opportunity piece is really important. So if I ever get the sense that I may be pushing an accompanying person a little bit too hard, I have to remember that as much as I want to have that opportunity to speak to the patient one-on-one, there's also this risk that if I make that accompanying person or that potential trafficker feel like they're at all threatened, that I might actually be putting that patient at increased risk when they ultimately end up being discharged and returning to a home with that accompanying person. So I am cognizant of recognizing some of those limitations. And so that kind of raises the discussion about, are there discrete ways that we can provide resources? So, some institutions kind of have a practice of putting a phone number for the Canadian or for a human trafficking hotline in a lipstick tube, or something that you think is going to be a safe way for the patient to access the information, or taking use of opportunities like when a patient is going for a chest x-ray for, they've come there for some reason, be it their cough or their broken arm or whichever. So if you're using that opportunity to say, this is radiation exposure, truly you cannot go in the room with the x-ray, that is a hard and fast hospital policy, using that as an opportunity to go in with the patient and do some screening, maybe over at your imaging.
Yeah, I think it's important to remember that they're often hardwired, and if you come hardwired to mistrust. So if you come off as a combatant, you're just going to be providing fodder to the trafficker, that you are unreliable, and see, this is exactly what I told you about, and we're never going back there again. So you want to, create as best you can the allyship in that moment. And as you talked about, Julianne, is if you're going to leave telephone numbers or leave other bits of information, to be cognizant of the fact that, again, you could be posing risk to them if they're found. So a lot of this is instinct, and a lot of this is the intuition in the moment and knowing when to say something. Sometimes it's a look, sometimes it's a lean in, and knowing when you pick your moments as you're getting them a gown or as you're, doing something. Yeah.
Just one last thing to add on, if I could. So I think that all of what has been shared is relevant, and Lord knows I've used the x-ray, whether it's been pertinent or not, because you can think of those spaces where it's pretty well known whether visitors are not allowed because, of course, of that exposure to radiation. So always be thoughtful about those spaces. But please keep in mind that every person who is accessing you for healthcare has the right to privacy. So as much as this is universal, as much as this is routine, then it doesn't feel awkward and in the moment different. And once it becomes that environment that this is for everybody, this isn't unique and distinct for this one person, then people tend to calm down a bit. There are some people that absolutely 100% under no circumstances will leave, and you just have to be able to negotiate that and try to reduce, use your nonviolent crisis intervention type of skills to be able to sort of diffuse those situations. But just remember that every person needs privacy, and it really should be universal, you at least starting with somebody and then offering that moment. And I would certainly encourage you not to ask in front of a client. I see it too often. Do you want this person to come with you? And then you're making it about that client deciding. That is your decision as a healthcare provider and the policy of your institution, that these are the rules that are here and the rules apply to everyone. So as I've mentioned, COVID just made that easier because people knew that they couldn't come in. But certainly the more that it is universal, the easier it is to be able to process and to implement that.
I love that when our institution's policies work in our favor. Sometimes that's incredibly beneficial. I'm going to move on, might be the last question of the evening as we're hoping to wrap up at 8 p.m. But one question was, is the incidence of being trafficked or of being a person experiencing trafficking higher among marginalized groups? And are there specific resources for Indigenous persons, Indigenous women and girls? And how would we potentially access those or be aware of those?
So I can start. So in terms of resources that are available, so with the funding and with the increased knowledge around human trafficking, some sort of various funding proposals. And a lot of times for those streams of funding proposals have included our Indigenous population. So whether you are looking at a population that is Inuit, a population that is First Nation, Métis, there are definitely resources in each province and territory. And a lot of times your victim service advocate might be a person who's able to adapt and sort of relay that information for you, because it can sometimes be very population specific and province and territory specific. How to Eat is a resource, and I can maybe find it and put it in the chat or somewhere so that it can be distributed to your attendees. But they have some wonderful resources in terms of looking at an Inuk or Inuit population. There are definitely resources that have come out, certainly in Ontario. I can provide a few more links in that as well, but how to Eat in that as well as from Nunavut and sort of from areas in our Northwest Territory. So there's definitely an attachment and the call to action that is our missing and murdered Indigenous women inquest has definitely had a few recommendations, certainly more than one, that involve healthcare and a call to action in terms of resources, and those being Indigenous specific. So under no circumstances will you be at a loss of finding resources to be able to be helpful for both you as well as your client. I think in terms of looking at marginalized population, it can land on where it is that you define that and how you define that. But I think so too within that network, we'll be able to find either peer type of resources or service specific type of resources. But I think as an umbrella, no matter where you are, connecting with your victim services may be an important first step.
And I think that the whole notion of vulnerable communities at greater risk for exploitation is in another evening conversation altogether. And one that was recognized, thankfully, by Ontario, the Ontario PATCO, Provincial Anti-Trafficking Coordination Office, and other arms, women, status of women, et cetera, public safety, to provide increasing numbers of organizations who are Indigenous, and even outside the GTA, which a lot of money tends to get funded into in Ontario, with the opportunity to build services from within their own communities. So there's increasing numbers, like I said, of organizations in further north, further east, west, and outside of the hotline number that if you call that number that they will provide you, they'll do a geomap and say, if you're in Blind River, you need to go to this organization, you can call here. But also on the website for Ontario, at the very least, that there's a list of all the Indigenous-led initiative fund recipients. and the different organizations and activities and services that they are in the midst of developing and being able to provide, and as well as survivor-led, that as they are able to branch out and provide, it was housing first of all, and now it's survivor-led, and now it's initiatives around the Indigenous communities, and hopefully the circle will widen to be able to support all people who struggle with this.
Thank you all. And the last question of the evening that I'm just going to close out with, I'm going to direct towards Fiona. I'm just wondering if there's anything that any person you've worked with or a client that you've worked with has disclosed about a piece of advice that they found helpful or an approach that they found helpful being within the ED or healthcare environment that they shared with you.
Yes, they've shared quite a bit of things, and I've had some experiences with clients in the ED as well. We noticed allowing the patient time, not rushing them is very important. So kind of working at their pace. I know that the ED can be really busy and it's hard to, sit with them for a minute or give them that time to really process things. But giving them a chance to feel comfortable with you, right? Not feel pressured into answering your questions, being patient with them. Asking them what they need at the moment is a really important one as well, what they feel they can use your support with or what they can benefit from. And just having someone listening to them, not judging them. I feel with patients, when they're not feeling judged, they're much more open, they're much more receptive to support. When they feel like they're being rushed and pressured, they won't open up as much, right? And the thing with this is when you're working with survivors or someone who's being trafficked, you may be that only person or that one person that they're willing to open up to. So it's really important just to be mindful of the cues that they're giving off. And if they're starting to open up to you, don't shut them down right away, but be open and receptive to them, knowing that they may disclose something or may be asking for your support. And letting them know that you're there to support them, right? You may not have the answers in the moment, but you can connect them to the right supports and right resources.
Being cognizant of the time, I'm just going to close out this evening. We do have a few more questions, but they've very much been touched on within the presentation. I just want to share my takeaway this evening, and it was said by Tara, but we are there to empower and not to rescue. And I think that's a very, very important sentiment to take forward, which can be an interesting standpoint for a physician, as we're used to being the ones kind of with the solution, but here we're there to empower and to validate and truly taking the lead from the person who's given us the privilege of having that opening with them. I want to, again, this evening, extend my incredible thanks to every person who has come to this presentation, but also those who are presenting, to Tara, Juliana, Fiona, and Julie. We are incredibly grateful for your expertise that you bring, and you've taken the time to create these slides and be present with us this evening. I cannot thank you enough. Thank you, everybody, for joining. We greatly appreciate it. And this closes out this evening's CAEP National Grand Rounds on Human Trafficking.